evening. I hope you're all having a lovely evening. So we're going to talk about women and mental health, and I must say this was an absolutely vast topic. I wasn't quite sure where to start. So I've tried to give a sort of basic outline and cover what I think must be important to all of us. So what I'll first talk about is the value of mental health, why this is important. And then just to touch on mental disorders, what they are, and psychosocial disability, as well as the burden of mental illness in women. And then to just discuss how it presents and what is the impact of mental illness in women over the life course. And finishing with the path to transformation so that we can have mental health for all. And I see somebody's raising a hand. Is there a problem? Can you hear me? Daisy's raised a hand. 2 participants raised hands. Am I to answer those, or?
No, I think
just continue.
You just continue. I think the Secretariat will...
Okay, so it's not because there's a problem. Okay.
No.
Thanks, Margaret. So why is it important? So mental health is intrinsic, actually, to our functioning, to our connection with others, to our ability to cope with life adversities, which are normal stressors. It is also normal to not cope with severe adversity and eventually to thrive. So what does this mean? It means that we can have positive relationships if we're mentally healthy. We contribute to our communities. We have a sense of belonging and we empathize with others. We're able to learn. We've got cognitive skills, so we can learn, we can memorize, we can pay attention, we can get an education, we can earn a living. We make healthy choices, we live healthy lifestyles, and we continue to learn throughout our lives. Our brain is amazing. It is the one organ in our body which can continue to change and grow throughout our lives. And in so doing, we deal with stress as we live through our lives and engage with others. We adapt to the changes we come across and we adopt new ideas. We make complex choices and we understand and manage our emotions. And finally, we realize our abilities. So we come to our self-actualization. We are able to feel good, to have a purpose in life, and to think about our well-being and the well-being of others. And you can see how the empathy and compassion speaks into that. So if we could all behave like this, then we perhaps would have a society which is calm, contained and collected and progressive. But as we're well aware, we don't seem to have that. And we certainly don't seem to be able to manage our emotions on the streets. So what is the difference between mental health and a mental disorder? And I quite like this diagram. It's a little bit different to our usual way of diagnosing mental illness. We've developed a categorical system of diagnosis, and this is what you kind of see at the bottom of this chart. And here they're just outlining the most common problems, which is anxiety, mood disorders, such as depression and bipolar disorder, and psychotic disorders such as schizophrenia. But we're moving towards what is called a dimensional approach and a kind of spectrum of mental illness, from being well, having no distress at the top, fully functional, as with our previous chart, to having non-specific mental distress. And this is something I think we're all familiar with, is that non-specific distress. And this is not a mental disorder. Feeling uneasy, a little bit of anxiety, tired, some lack of energy, fatigue, worrying, feeling like you're not coping is not necessarily a mental disorder. It moves further, though, to more severe symptoms. So anxiety is the most common. And anxiety actually could be seen as part of normal human condition as well. So when we start talking about anxiety as an anxiety disorder, what we're saying is the level of anxiety is so severe that we're unable to function and to cope with normal stressors. So it's impacting on our day-to-day lives, on our relationship with others, and our ability to work or learn. We may have somatic complaints, go into avoidance and panic. So you can see the progression of severity in the mood syndrome with depression they've shown us. Mania is obviously also there and can be both the low mood and mania can be exceptionally severe and almost paralyzing with depression. And then psychosis with hallucinations and delusions. So what the chart doesn't show you, and what you would have sort of on the left of the chart, is a similar progression for neurodevelopmental disorders, which would include intellectual disability and things like attention deficit, hyperactivity disorder, eating disorders, and then on with another one, which also would progress from mild to severe. And on the right of that chart, I would put our neurocognitive disorders, so our dementias and our degenerative disorders with old age. The importance of this graph and this sense of progression, it doesn't necessarily mean that a person who has mild illness or mild symptoms, some insomnia, some lack of energy, feeling of not coping, which is for a short period of time, is going, that doesn't mean that person will progress to a severe condition. It rather means that when we address the nature of the complaint, we do so at the level of severity of the complaint or the presentation. And the problem in women particularly, though, is that our severe symptoms may not appear severe to others. So we may go unrecognized and our problems go, our illness goes unrecognized. Just thinking of another way of describing this, and I would say if you've got someone up here with a sprained ankle, so they are fit, they're healthy, they've gone for a run and they've sprained their ankle, you would treat it as such. It doesn't mean they're going to progress to some condition like rheumatoid arthritis, which is a discrete condition in somebody who's genetically predisposed to it. The same here. You might have a low mood here of madness. Doesn't mean you're going to progress to severe depression. But we like to think of it on this spectrum so that we can consider our interventions appropriately. So what is psychosocial disability? This is a form of disability that, which it results from mental illness and intellectual disability, which impairs a person's ability to function, especially in terms of their interpersonal functioning with others, their ability to learn, their ability to attend to new matters, to change and adapt to new stressors, to cope with any sudden disruptions in their lives. And so these are people who are who find it difficult to function in the course of their daily life. And what the Convention for the Rights of Persons with Disability has stated is that people with all disabilities should be enabled by society to function so that they can participate fully, the same as anybody without any disability. And for psychosocial disability, this means that society has to play the part. They have to pick up the tab of that person who's finding it difficult to cope. So the support that gets given is interpersonal support. It's social support. It's adaptation of services to meet the needs of that person. And this is really important in terms of access to care. So what I've shown here is the concluding observations on the initial report of South Africa by the Committee on the Rights of Persons with Disabilities. And it is grim reading. we have 4 positive aspects, which are all noted on the front page that I've got there. And we have 13 pages of areas of concern and recommendations. There are 28 comments stressing the need to address the needs of people with psychosocial disability, and a very strong emphasis on the needs of women, girls and women with disabilities in accessing healthcare, mental health care, and any of the other services in society, educational services, social development, home affairs. There's a very strong emphasis that these girls are not only neglected, but abused in our society. This is a copy of the 2022 report. I'm not sure if you're all aware of it, the World Mental Health Report. So this follows on the 2001 World Mental Health Report from the WHO. And I think it's quite significant that they have placed a woman and a child on the cover. And I really would recommend that you read through it. It's got a lot of very easy to read explanation of mental health, and I've taken quite a few of the illustrations for this presentation, but a large focus on the needs of women who have been neglected and in our mental health system. So our mental health system is very poorly functioning in South Africa, and it is particularly neglectful of both women and children. If we look at the prevalence of mental disorders, this is taken from the Global Burden of Disease study. And what we find is that mental disorders are about 5% more common in women than in men. And the more common ones tend to be anxiety, depression, and post-traumatic stress disorder. The reason for this is probably societal, and it's worse in countries where there's more gender inequality. So it's worse in low and middle income countries. We don't know how much worse it is because we've got far less data coming from our lower and middle income countries. So if we have a look at this graph, it tells us the percentage of the global population living with a mental disorder. Overall, they reckon it's about 13%. And it seems to be less prevalent in low-income countries and middle-income countries. However, this is very likely related to poor data collection. We've got no registries and electronic data at all in these countries. And the difficulty in conducting large surveys, as well as that is the difficulty in conducting surveys using questionnaires which have been developed in high-income countries. And then you have to adapt that not only to the low-income country, but you need to adapt that to how women in low-income and middle-income countries experience their illness. So, for example, when you're asking about depression, and when I ask my patients about depression in the township population, I will find it particularly in middle-aged women that they very rarely tell me they feel sad or they've got a low mood. Some of them stare blankly at the thought that they might have a mood. And the concept of anhedonia, of having no pleasure in life, is completely foreign. What they complain of, thinking too much, headaches, neck pain, and loss of energy, tiredness, inability to concentrate. So it's all in neurovegetative features. And these might not be picked up in the surveys, which focus heavily on low mood and anhedonia. So reason for higher prevalence in women might partially be genetic predisposition, but it's also very likely to be societal effects and burden of home care, responsibilities for family, and difficulty in getting equal pay for equal work in low and middle income countries particularly. So this chart is just to illustrate, and I don't want you to go through the whole thing, but I just wanted to illustrate at the top, firstly, the life course that we talk about with our age groups. that mental disorders, if we look at all ages, they're slightly more common in women than in men. But if we look at the adult age group, they're a little bit more common in women than in men, than when you look at all ages. And that's because we're not, we either don't have or we're not identifying mental disorders in children and adolescent females, whereas we do in boys. And this may be related to them not presenting with disruptive behavior. So if I take you down here through to ADHD, so ADHD at all ages is less common in women. However, when you start looking at the adult population, ADHD is more common in women than in men. Now, ADHD classically presents in early childhood or primary school, but possibly not being recognized in the girls, and so being thought to be not present. And this is because girls present with inattention, daydreaming, drifting off in class, and they're not disruptive, so they don't get attention. We can see that very severe mental illnesses, so psychotic disorders and bipolar disorder, are the same in both men and women. These are very strongly genetically, the genetic predisposition is very strong in these two conditions, particularly bipolar disorder. And the ratio is 1-to-1, but the presentation might be different. And then, as I said, depression, anxiety, eating disorders, more common in women. So the burden of mental disorders in women is also greater than in men. And here we see the burden of the disease. The difference is actually bigger than the difference in prevalence. Here we've got about an 8% difference, whereas in prevalence we've got about a 5% difference. The way that we've measured the burden of disease here is something called DALYs, and these are what we call disability adjusted life years. So we measure the burden here in the years lived with a disability and the years lost to life. Mental disorders tend to have their biggest impact on disability rather than on mortality. Although there may be about 10 to 20 years lost to life, the disability starts early in life and continues right through until later life. Most disability is related to depression and anxiety, but mostly because these are so prevalent. And then schizophrenia punches above its weight, as does bipolar disorder and as do eating disorders. What I mean by these is that the disability they convey or cause is far greater than the prevalence of these diseases because of their severity and the loss of function that they cause. So possible reasons for why the burden of disease may be more in women than in men. And some of these reasons won't have been measured there, and so the difference could actually be even greater. So the obvious one is that the slightly higher prevalence of depression, anxiety, and conditions like PTSD in women would confer a higher burden of disease, but also that the disabling impact in a woman might be worse than in a man. So firstly, the disabling impact is cumulative with societal discrimination. So if you're in a patriarchal society and you've got a mental illness, you are more likely to be rendered helpless or unable to assert yourself, unable to get a job, and unable to shift across the boundaries of society if you have a mental illness. So it adds on to the discrimination that may already be present. And the other impact in women is we tend to be more responsible for our family welfare, for our children and other dependents, our elderly parents, even siblings. If we have a sibling or a cousin who has an intellectual disability, very often it might be the woman in the family who really take care of that person. certainly the interpersonal care, if not the financial care. So the impact of something like depression in a woman doesn't just affect that woman's ability to function. It affects her ability to feed her child. So we see children with more malnutrition, with diarrheal diseases in women when the mothers are depressed. Other aspects are that women have a reduced access to mental health care than men. And there's several reasons for this. So the first is that the symptoms are often more subtle. They're less disruptive to others. And so there's often delayed help seeking. But we find in our country, people are usually brought in for psychiatric help because the family or the community can't tolerate the behavior, which is aggressive, violent, and extremely disruptive. Whereas with women, it's more that there's a complete loss of energy and loss of cognitive functioning, and they become isolated. Another is that our health system, our mental health system in this country is heavily focused on hospitalization. In many provinces, this is almost totally in standalone psychiatric hospitals. And this is not appropriate. It's not approachable, it's not acceptable, and it's not affordable for most women. Women do not want to leave their families and their children and go into hospital for 3 months at a time. So the unaffordability is very often in terms of time away from the home, as well as the transport costs for remote hospitals. Hospitalization is also stigmatizing. And once you're stigmatized as a woman or a mother, this really becomes quite unacceptable. And the biggest threat to many of our patients is that their children will be removed from them, which is obviously what does very often happen. So they would rather not seek help and go into hospital and have that possibility entered into. And then for the unacceptable adverse effects of medication, a big reason why women don't like our medication is that it very often causes weight gain. And this may be a problem, particularly in young adulthood. So we have delayed care in women. They come in and sometimes you're going through the history and you realize that they've actually been severely ill for 10 years and continuing to try and struggle on. We have progressive disease, which only worsens with time. And so we increase the burden of illness in women rather than in men who may become more aggressive, more disruptive, especially if using substances. So I'm going to shift a little bit and go to the life course approach. This diagram is taken from a website of a women and children's hospital in Singapore. And the diagram is the life course approach to maternal mental health. So I'd recommend it's a very brief read, and it gives you quite a nice overview of maternal mental health. I used it because I think it illustrates our life course very well. I don't want to insinuate that women must have children and that we're only of value when we have children. That is not the purpose of this, but very often we do have children. We are the ones who bear the children. We are the ones who very often are left to raise the children, very often alone. And our family obligations do play a huge part in our lives. So it's very difficult not to show women with children. However, this does not mean that a child-free woman doesn't have value and isn't contributing to society and may not have health problems, because obviously they may. So just to start with the life course approach, we'd start in utero with our fetal mental health. So we think of the baby's development, and this is obviously very largely biological, and we're worried about how is the brain developing in utero. And this is influenced by genetic predisposition and our genetic blueprint, the intrauterine environment in terms of nutrition, infections, substances, which affect the blood flow and affect the baby's development, but also by maternal stress and a high and maternal cortisol levels. Of importance with cortisol levels is they cross the placenta, they affect the baby's brain development, and they are associated with an enlarged amygdala. The amygdala is that part of the brain which interprets fear and threat. So when a baby is born with an enlarged amygdala, they may be hypervigilant already from birth, and having difficulty with emotional regulation from birth throughout life. So the environmental importance of this is not only the maternal physical health and nutrition, but maternal stress. And we really need to start focusing on reducing maternal stress pre-conception to improve the in utero environment and the baby's development and the brain development and emotional development. And the stress may be interpersonal, financial, or through safety and security. So through violence, the gender-based violence we have in this country, through domestic violence. And maternal mental illness, so depression, anxiety, and more severe illnesses are all associated with raised cortisol levels and so also some raised inflammatory cytokines at times. So the importance here is not just us as pregnant women, but this is our start in life. We start our lives as a little bundle of DNA, and which multiplies, and the cells multiply, and our brains develop. And when we're born, we're already starting to sense our environment and whether we can trust or mistrust it. So we come to infant mental health. And I'm using here the Erickson stages now of development, of psychosocial development. So it goes up to 18 months, the first stage of development. And he calls this trust versus mistrust. So what happens after birth is we start to learn that our environment is caring, nurturing, will look after us, stop us from being hungry, cold, frightened, and console us when we are, when we're disturbed, when there's noises, and so on. Or we learn to mistrust it. And the predisposing factors to mistrusting our environment would be inconsistent caregiving and abuse. So inconsistent caregiving can be anything from a mom who herself hasn't developed her own sense of self, struggles with depression and anxiety herself, so sends mixed messages to the child, has lots of energy, is engaging, very animated face, plays with the baby one day, the next day can't stand the sight of the baby. And again, just going back to us as a baby, that's going to impact us as women and how we bring up our children, and us as mothers, which we'll come to later in our life's course approach. The diagnosis that we usually make at this age in the first 18 months is really around an intellectual disability, and usually it's between your moderate to profound intellectual disability that may present at this age. Occasionally, autistic spectrum disorders might start to present in very severe cases, but they're very difficult to diagnose until later. And the predisposing factors for these diagnoses are poor intrauterine development and obstetric complications. So completely avoidable most of the time to have such severe intellectual disability. Our next stage would be 18 months to 5 years. And here we may see mild to moderate intellectual disability appearing. Autistic spectrum disorder may become more apparent because language is developing. So autistic spectrum disorder tends to be diagnosed more in boys than in girls. And when it is present in girls, it tends to be more severe than in boys. And I'm not entirely sure if that's because we don't recognize it in girls, because girls' language development may be slightly better than boys, and our standard of assessment may be different. Or whether it really is different in girls and boys. The other diagnosis we often make in this age group is enuresis and or encopresis. So enuresis is wetting your bed at night, or loss of control in the day if it's diurnal, and encopresis is soiling yourself during the day or night. So enuresis may be perfectly normal, and it may be something in that child causing a later development. It's very often associated with anxiety, which may be related to the genetic predisposition or the home environment or the parenting style, or the child's inner temperament. Encopresis is often more of a behavioral disturbance and may be related to much more disruptive home environments and abusive home environments. And obviously in little girls or any children, we always examine for sexual abuse if there's encopresis. The psychosocial development process here is autonomy versus shame and doubt, which goes up to 3 years, and initiative versus guilt between 3 to 5 years, so in preschool. And really there's very little difference here between between girls and boys. Generally speaking, obviously. What impacts your shame and doubt versus autonomy is very often the parenting style, the teaching style in the preschools, but it may be the predisposing abilities of that child. So a child who's got a mild intellectual disability or low average intellectual functioning may start to experience feelings of shame and doubt as he starts to, or she starts to compare herself with others. The initiative versus guilt is when they start being independent, making their own decisions, and here the parenting style really has a very strong impact on this. So the importance here when we're looking at our girl children is cultural factors, whether girl children are less valued than boys in a culture. So is the shame and doubt imposed upon them? And if they are overly independent, if they're a little bit assertive, are they made to feel guilty? That's not the way girls should behave. Clearly, we want our girls to be assertive and independent, and we'd like them to say no, particularly in potentially abusive situations. So this becomes a serious problem later if these stages don't get resolved. And what you hope with these Erickson stages is that you resolve them to the positive before you move to the next stage. So your little 2-year-old who's struggling with autonomy and is having 2-year-old tantrums, and that little girl is made to feel shameful and have self-doubt, is likely to also have more guilt in the next stage of development. And that will translate to further behavioral problems. So when they're having their 2-year-old tantrum, your parenting style needs to be less authoritative, perhaps, and less authoritarian and more authoritative. So to recognize the independence of the child and to be able to set suitable boundaries in a way that preserves their sense of autonomy. As we come into primary school, and our diagnosis here, usually ADHD is when this presents. This is markedly under-recognized and under-treated in South Africa. We really are not addressing it at all, not even in boys. So in girls, I'm sure it's been hopelessly missed. So in girls, this would normally present in a much quieter way than in boys. As I said, they're usually inattentive, they're daydreaming. However, they suffer the same social effects. So there's often school dropout. They may be more likely to smoke cigarettes, to get involved in more antisocial behavior, which in girls will often be inappropriate sexual relationships, sometimes with older men, with blessers, because there's more impulsivity, there's less self-control, and a lowered ability to delay gratification. Again, your intellectual disabilities may only present here, and we do have children, again, in South Africa particularly, where they don't progress from 1 year, where they are pushed forward from 1 year to the other at school, until a mom or a parent realizes that they have a slow learner as a child and wonders what's going on. The danger, again, in children with girls is that these girls are very high risk for being sexually abused, extremely high risk. And predatory men can spot them. They spot the walk, the gait, the facial expression, and they'll take full advantage of these defenseless children. And we still may diagnose autistic spectrum and enuresis and caprices, but if you have now got enuresis and encaprices, we are much more concerned about an abusive environment or severe anxiety state in enuresis. Psychosocially, it's industry versus inferiority. It's all about work at school at this age. It's all about succeeding in your school environment. So we now have this paving the way for their social and peer relationships in adolescence. If they start to feel inferior because they're not coping, and that's going to pave the way for whether they feel included and are able to make friends, versus being industrious and feeling that their industry is paying off. Adolescence hits, and it hits hard. And what really hits hard during adolescence is all of that early childhood development. Any abuse, gender-based violence in early childhood, home abuse, domestic violence, disruptive living, moving from place to place, lack of security. Now the parents or the grandparents are going to pay. And now we start seeing severe anxiety, the eating disorders start to present. We may still only see ADHD now in our girls, and we still don't often recognize it. And we, again, may start to only see our low average IQs now. We still now may have elimination disorders, and encopresis at this stage is a strong sign of sexual abuse. And I remember when I was a PhD doctor at Witkoppen Clinic, having a young girl of 17 years, she was only identified as having been chronically raped every day by a stepbrother for about 10 years, because she was sitting in school and she was soiling herself daily. Nobody could sit next to her because of the smell. You can just imagine the isolation that she experienced. And it took that long for a school to realize that there's a problem, that this is not just a behavioral problem, and to refer her for attention. By that stage, she had HIV. She had been tattooed by this boy. She had been tied up by him. It was horrific abuse, presenting with severe encopresis and the most profound depression in a 17-year-old girl. So behavioral problems at this age, you've really got to take absolutely seriously at any age. And the first port of call is to think of the family and the home, not to blame the child for having a behavioral problem. The psychosocial development now is crucial. And this is when we should be forming our identities, our sense of self. And unfortunately, our high schools and our environment is all about success. In the private sector and in the government sector, it's, I suppose, the same, but there's very little attention to each individual to help the child to start deciding on who they are and having that sense of self. So Role confusion is the poor sense of self. When there's a poor sense of self, we now start to have very high-risk behavior, self-harming behavior. They're highly exposed to violence because of the high-risk behavior, especially substance use and contracting of STIs, HIV, unplanned pregnancies. So the most common cause here would be this role confusion and the poor sense of self. We may start seeing conditions like bipolar disorder at this age. Adulthood, we now start seeing bipolar disorder and our psychotic disorders. They present slightly later than in men, in women, but they've generally presented around about your 30 years old. This is also the time we're forming intimacy versus isolation, and we're developing our relationships and we're setting up our homes. The associated factors are very similar to what we've seen before, but just to emphasize again, the poor access to mental health care, because we don't recognize it. And we've seen this in our media. We've had this poor woman, Gosiyama Satoli, who was just everything splayed across the media, and nobody considered, does she have psychosis? What is going on here? Everyone just thought that they could talk about her personal life at free, but she had never in her life accessed mental health care until that time. We cannot go without talking about perinatal mental health. And we must remember that maternal mental illness increases our risk of poor maternal and fetal outcomes of pregnancy. And I've listed them here in accordance with the severity of the mental illness. So depression, anxiety, PTSD, all mental illness will increase your risk of preterm labor and low birth weight babies. Bipolar disorder increases the risk of hypertension, preeclampsia, and schizophrenia will increases the risk of gestational diabetes. Neonatal morbidity, more likely to be admitted into hospital after birth with the newborns, and bipolar disorder, more likely to have a stillbirth in schizophrenia. And then all mental illness, you've got a higher risk of emotional and mental disorders in the child. So something like maternal depression increases your risk of autism, of autistic spectrum disorders in the child. And then, of course, you've got all the associated factors which also worsen the maternal and fetal outcomes of pregnancy. So just to add that these outcomes are adjusted for these associated factors, which would exacerbate the previous outcomes. 40 to 65 years, we are supposed to be generative. We are now highly functioning. That's the reason I'm giving the talk, is I'm now in my stage of generativity. It's the reason Margot is hosting it. We are generative, and as women, we become mothers to everybody. We want a better society for the next generation. And this would be a sign that we have passed through all our other phases successfully if we are managing to be generative in a balanced manner. So I have to confess, I haven't passed through everything successfully. My generativity is not always balanced. I might be quite excessive in my dedication to work. Okay, diagnoses remain similar to before. Associated factors remain similar to before. But if we stagnate now we start seeing all the analgesic abuse. This is the age group, middle-aged women across the globe who are abusing opiates and other analgesics, avoidant behavior, dependent behavior, and prolonged domestic abuse with an inability to get themselves out of it. After 65 years, as we head towards the end of our lives, we now reconcile ourselves with our lives with integrity, or unfortunately we die in despair. So I think in women, what is really poignant at this stage in our lives is our relationships, the way we reflect on our relationships, the satisfaction we've had in how we've brought up our children and those relationships. And it's really hard now to go back and to repair broken and damaged relationships. So when these are not reconciled, we may have severe loneliness. Avoidance and dependence may be worse. We become relatively immobile. There may be excessive somatization and analgesic use. And because we've got our degenerative changes in the spine and our joints, we start to have lots of surgery, and we may start to see quite a lot of requests for surgery or need for attention in the health system. We become vulnerable still to violence and abuse. PTSD is still common, but the new diagnosis that we start to see here is our neurocognitive disorders, our dementias, which develop at this age. And because we live longer than men, we are more likely to develop dementias than men are, and to be more dependent on others for care. So just to finalize and to make it a little bit more optimistic, I've taken this slide from the World Mental Health Report, which is about transformation for all, including women, and with, as I say, a strong emphasis on women in the report. And I thought I'd just run through their paths to transformation, which are intersected and interrelated and should all work in conjunction with each other in view of what we need for women. So in terms of deepening our value and commitment, this is actually really about politicians. This is about our government and our society, our neighborhoods, our families as well. We need to understand and appreciate how important mental health is. We need to realize that this is what helps us, what gets us going, and what enables our functioning. And with that commitment, we need to be committed to improving what we call social capital. That is our social relationships, our trust of each other, and our ability to reach out a helping hand to somebody who is more disabled, who may have that cognitive or psychosocial disability that might make them a very difficult person. So we need to start placing such people and get in higher priority and lifting them up with equity. We have to reshape our environments. So every environment needs to promote mental health in women. Our homes, our schools, our workplaces. So workplace mental health there's a lot about it at the moment. Essentially, it revolves around creating a workplace and communication in a workplace, which fosters mental health of all employees. So it puts a lot of stress on managers and CEOs. They're the ones who have to foster that environment. So they need to also look after their own mental health. It's not actually about just sending people for counseling and for mental health support. Now, for women, it means the workplace we have to start thinking of ways to adapt the workplace to women's needs. And this is not so easy because I think for most women, we need more flexible working hours. We want to be able to go off and pick up a child, take them home, maybe come back to work. We might need to work from home on certain days. We might need more childcare services in the workplace. And our predominantly male-run workplaces might not find this very convenient and easy to adjust to. I've already mentioned our schools in terms of recognizing when a girl is behaviorally disturbed, recognizing the role of things like ADHD or abuse. And then strengthening mental health care. So the most important thing about mental health care is we've got to start decentralizing expertise, mental health care expertise. It's no good just saying, well, we're going to start making CHWs, community health workers, provide mental health care when they cannot address the needs or make a diagnosis of something like bipolar disorder. And it's no good expecting a woman to be admitted 40, 50 Ks from home and to leave her children at home in order to have that psychiatric assessment, diagnosis, and treatment. And the treatment has got to be done in conjunction with the social support system of the woman. We've got to understand everything that's going on in that woman's home. How is she able to look after the children? Is there a way we can keep her children with her if we can provide more support? And that's where our CHWs and home nurses might come in. So these are the paths to transformation from the mental health report, and I would very much encourage you all to Google it and to get it and read it and start advocating for these changes in our society. Thank you very much. I haven't gone too much over time.
Yeah, no. Wow.
A little bit.
Incredible, layered presentation that really makes one think all the way. Every new slide really touches one's heart and one's mind, and you just can't get around all the issues that are at stake, and just realizing how complex mental health is and how important it is. But there are quite a few questions. Maybe I should just open that up. I didn't want to do it while we were presenting, worrying that it might disturb you, but shall we just go through? Can you see my screen now or not?
Yes, yes, I can see your screen.
Okay.
Yes, and if you like, I can stay a little bit later, but I don't know about your timing. I just see there's 6 minutes left.
Can I just ask the Secretariat, are we allowed to go over 7 o'clock? Can we stay like till 7:10?
We can allow it until at least 7:05.
Okay. All right. So we'll just have to limit our questions and answers. I think the way to get around it, one can always look at them and respond later, Lesley. Maybe you will have time to respond to that. But let's look at here. This first one was here. We work with shelters for abused women, and more frequency women with mental health disorders when they reside at shelters. I don't know if there's something you want to mention about that specific situation, maybe.
Yeah. So I said, Zubeida, I think this really needs to be taken up with social development and the mental health directorates. We're having a huge problem in the division between homes, if you like, because as you say, women with mental health disorders are residing at shelters, and most of these shelters are funded under social development. But as soon as you've got a mental disorder, you start falling under the Department of Health. So yes, you could contact me or email me, but I think your best way is to initiate discussions between social development and departments of health as to how to access care for the women staying in your shelters, and to appropriately.
Okay, thank you, Lesley. Then just on some natural treatments and support severe anxiety or uncontrollable panic attacks, maybe just some enlightenment on that.
So I think with anxiety disorders, we go for psychotherapy. So meditation is not going to manage a severe anxiety disorder. And I recently saw a very well-run, well-conducted study looking at an intense yoga program with meditation compared to cognitive behavioral therapy. And while the yoga program did alleviate this anxiety to an extent, it was not as effective as the cognitive behavioral therapy. So I would recommend, if you don't want to try medication, I would recommend actually having psychotherapy, particularly something like cognitive behavioral therapy, which has got evidence for severe anxiety. And then making sure that it isn't something else underlying it. So is there actually a mood disorder which may be underlying the anxiety disorder? Or could it be related to the developmental pathway and personality or psychosocial problems, which would need a different type of psychotherapy?
Right, thank you. Then I don't know if we should even touch on suicides, and is it more common among women? Yeah.
All right. So men they have more successful suicides than women. Women may attempt suicide more often than men. So it's probably related to the methods which are used. Men are more likely to use more violent methods, and they may be more likely to have access to guns or weapons which are going to be more final. So women tend to attempt suicide more and use less violent methods, particularly overdoses are more common in women. Some cutting, but usually the cutting is not as aggressive as in men. So, yeah. It doesn't mean we handle mental health problems better than men, necessarily. It might mean we just handle them differently. That's all. Maybe we are supposed to be more resilient, but I'm not not sure how.
Yeah.
Well, I don't know what the data shows in that sense. Yeah.
Then just for the PTSD stands for post-traumatic stress disorder.
Yes.
That is a quick one. Then is paranoia considered mental disorder, and how can people experience it be helped? I think that's one for you.
Sorry, okay.
Paranoia.
Paranoia considered mental disorder. Okay, so no, paranoia is a lay term, and it is just a general term which means that you have, well, I don't know how to define it except for paranoia, but you have a sense of something being about you, somebody talking about you, somebody's after you. It's usually a little bit vague, or maybe, so it may be feeling that most commonly that people are against you. You could say that people with conspiracy theories are a bit paranoid, and that's the way that they're coping with stress. So we've got a very disrupted world at the moment, and we see conspiracy theories coming up all over the place. And because their coping style is to become paranoid that somebody is planning and is against them. But it's not actually a mental disorder. Mental disorder is diagnosed when you have a clustering of signs and symptoms which impact that person's functioning. So a person might be a little bit paranoid, but they're still able to live and function in their lives, and it might be fleeting. And it can be completely normal. If it's a persecutory delusion, it's a psychotic symptom, and that's a fixed false belief that somebody is absolutely against you and trying to kill you. And it can be quite bizarre, but it could also be quite realistic. So it could be a belief that somebody's trying to poison you and you refuse to eat your food. Now you've got this is a delusion. It's a sign of psychosis. You still haven't got the diagnosis of a disorder, but that would be one sign of schizophrenia. Okay.
There's a question about the employees and management. I just want to point out that we have our next sessions in September will focus on management and safety, how you create a safe environment at your workplace. So maybe they should just join in there. Which might be a common one here. The contraceptive pill, can it cause depression? And what are your thoughts on that?
I don't think there's a significant association between the contraceptive pill as a cause of depression as a whole. So maybe an individual person might be sensitive to it, but I don't think there's any population level data to say that it's a cause of depression. It's more likely that it's comorbid.
Then this question, would mild physical disability as an infant, for example, poor vision or impaired hearing, be a predisposing factor for anxiety?
So that may be, it could be, and it might not be. And that would depend on the genetic makeup of the child, as well as the parenting style and the caregiving style, and the way that the child is supported for their physical disability. So any physical illness may be a predisposing factor for anxiety and depression, but I think it's largely related to how that physical disability is handled.
And I can just mention here that the recording will be made available if you have registered. So you can just approach the conferences department and they will be able to make it available afterwards for you. And then maybe just as the last question, the question about the 2-year-old that has a temper tantrum and they can drive you crazy.
Okay, so that's a webinar in itself. and my mind, I'm sorry, my brain's gone a bit, but the different types of parenting styles, I would just have to quickly get it to be certain. But one doesn't want to be too permissive, and you don't want to be too authoritarian. And my understanding is you want to have an authoritative parenting style. You are the parent. So I found parenting probably the hardest thing I've done in my life, and still do. And the psychologist would say to me, I think I took my daughter, she was about 5, she said to me, well, who is bigger? So you are not a victim of your child. You are the parent, and you need to look after yourself to be calm, collected, fair, and loving, so that you can set appropriate boundaries, reinforce them without undermining the child. That's as much as I could say there.
Yeah.